your models, things like that. Like the model in the back of the room back there, that's a sphenic body shape. That's the atypical average size throughout the world. Slightly below that, we'll go down bottom right, is hyposthenic. That's when we're going from average body shape to slightly skinnier. The heart gets longer and thinner as well. And of course, the skinniest, the asthenic, that's like your skeletal people almost. The heart's going to get extraordinarily long and thin. And once again, you're going to find the organs all kind of follow that same rule across the board. Please remember that. Please know all 4 body habituses. Yes?
What's the percentage in the population of each?
We'll get to that.
Okay.
We're going to come back to that.
It's been updated for the registry.
There's an updated one?
Supposedly.
Yeah, we'll talk about that. We're not going to get too far ahead yet, but we'll come back to that. Yes?
Yes, I have a quick question. How is the asthenic and hyposthenic confused? I feel like they're the same one.
They're similar, but hyposthenic's going to just be like a skinny person. Asthenic's going to be like a almost skeletal skinny person, like super, super thin. Like you can see their bones, their skin almost skinny. That type of skinny
So like
person.
a malnourished person.
Not necessarily malnourished, because you know you got those people that like they're so skinny that their bones poke out.
Oh, okay.
Those kind of people be like your asthenic. Hyposthenic's just going to be like a normal thin person. And then sthenic's just going to be the average normal body shape. Yeah. Okay, go over your topographic landmarks found that we use for the chest and neck areas. Well, there they are, guys. Please don't forget those. Maybe like, well, this is common sense, but you'd be surprised how many people forget these topographic landmarks and why it's so important, not only for positioning, but also when we talk about the levels of things. For example, T7, that's going to line up with the mid portion of the sternum. That's going to line up with other areas of the body. C7, vertebral prominence, that's also going to line up with different things as well. Jugular notch, it's synonymous with C2. You need to know those topographic landmarks, know what lines up with what. That's some random questions they might just throw in there at you, and something you can expect on your test as well from me. Make sure you know those topographic landmarks, know how they sync up with other areas of the body, and also know how we use them when it comes to positioning. Of course, T7 being the big one, that's really used for our what? Chest x-rays, our ribs x-rays, other things as well. T7 is one of those big ones you just can't forget. Jugular notch as well. How does jugular notch relate to a topographic landmark for a chest x-ray? For AP, very good. If the patient's AP and we cannot access T7, we're going to use the jugular notch and do what? Go 3 inches inferior to the jugular notch to get that AP chest centering. Is that ringing a bell? Y'all remember that? Yes? Also, xiphoid tip, synonymous with what, guys? T10 and T11, approximately. Make sure you remember that. And we'll review all these as we go through all the anatomy as well. What are the important topographic landmarks? What spinal areas do they line up with, so on and so forth. Very important to remember. Now, how well did you do your illustrations? Well, there's a great example right there. I think most of you did quite well on it. Of course, don't forget when it comes to the trachea, the bronchi, the bronchioles, that there are different sections that we're going to break down here on the following slides. Overall overview, guys, of course, we have the larynx, the trachea, we have the bifurcation area, which we call the carina, and most of you guys remember that, which is great. That's one of the big ones, by the way, big star on that carina. They love to refer to that. That's that bifurcation of the trachea to the left and right sides. We have those 2 primary bronchi, then they break into secondary, and of course the third is called the tertiary. So primary, secondary, tertiary, 3 main sections, left versus right. And if y'all remember, one's longer than the other. We're going to talk about that in a second. And of course, when we talk about the lungs themselves, they have numerous lobes. Y'all remember the lobes?
Yeah.
One side has 2, the other side has 3. We'll talk about that as well. Now, of course, the most small part when we're talking about the bronchi tree is the alveoli, which is composed of the alveolus, the alveolar sacs, and that's what helps us actually breathe. That's the microscopic element of the bronchial tree, the alveoli. Microscopic element of the bronchial tree. Let's see here. If I'm going too fast, y'all tell me to slow down. Now there's a great picture right there. That's one of the ones I want y'all to focus on because that kind of simplifies it a little bit further for you. Of course, starting at the top, guys, we have that area that contains the thyroid cartilage, the thyroid gland, and the parathyroid glands. Make sure you know where those are located, thyroids and parathyroids. We also have the area where the thymus gland is located. The thymus is right here in your chest. A lot of us forget about that one. One thing I want you to write down if you're having trouble remembering is the difference between the thyroid and the thymus. It's one of those easy mistakes I see a lot of people make, is they might be asking, what's the name of the gland found on the anterior portion of the neck, where the Adam's apple is, or the laryngeal prominence? That's going to be the thyroid gland. If I say, what's the gland found on top of the sternum, you're going to tell me the thymus gland. Even though you're seeing it in front of the trachea here, that's where your sternum is as well. Make sense? That's the often forgotten gland, the thymus. Don't forget about that. It's very, very small, very easy to miss. Now, of course, as we go down with the trachea, it does bifurcate, like we talked about, into two sections, a left versus right. And if you remember, the left primary bronchus is longer and more narrow. The right primary bronchus is shorter and more wide. You remember that? Coming back to you. Now, the right side has 3 secondary bronchi with their tertiary. The left side has 2 secondary with their tertiary. Therefore, what do you think that leads to with lobes? How many on this side?
2 lobes.
2 lobes on the left, 3 lobes on the right. It's coming back, huh? I hope so.
Can you repeat where the thyroid and thymus is located?
Thyroid is going to be at basically the level of C6 that you see on the diagram, but they also can say the anterior portion of the neck or in front of the laryngeal prominence. They're not going to say Adam's apple, by the way, they'll say laryngeal prominence. Thyroid sits right on top of that, anteriorly. Thymus, even though we see it in front of the trachea right there, is actually, bless you, more often referred to as being right on top of the sternum, the sternum.
Thank you.
Laryngeal prominence is C5.
Laryngeal prominence is C5, C6. You'll see variances there, but yeah. There's just other ways they can ask that question. They might say at the level of C6 or C5, but most often what I'm seeing is they'll say it's right in front of the laryngeal prominence, that general area. So it'd be good to write both those down. They can ask that either way.
And the parathyroid, so there's 2 thyroid glands, right, on each side?
There's one thyroid gland.
Oh.
There is a left and right parathyroid,
Oh.
which you kind of see a little bit there. But the thyroid is just like one referred to as one gland. Parathyroids, don't worry too much about that one. I've never seen them ask about parathyroids, but just know it's basically an extension of the thyroid. They're those little dots you see on there, by the way.
It's like the superior and the inferior.
Let's see what I'm talking about. This whole orange structure is the thyroid gland. Then you have left and right parathyroids. Here, 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 here. That makes sense? There's 4 of them. It can be more or less than that, but in general, about 4. That's just what it worked. You have nice things, gang. Let's go buy a new clicker. All right, so like I said, guys, a little bit more about the bronchi. The right primary bronchus is the shorter, wider, and more vertical than the left. It also has how many lobes connected to it?
3.
You're asking for the right or the left?
Left.
Or were you, I'm sorry, I didn't hear your question.
The right, how many lobes are connected to the right?
3 lobes.
3. And once again, 2 on the left. Please write that down. That's something people often forget as well, about those lobes, their placement. That's something I used to forget as well. Easy to mix those up. As far as labeling the lobes, I wouldn't stress too much about the actual labeling of the lobes, but make sure you know the number of them and how they correspond with the number of bronchi that bifurcate. That's something I've seen them ask. That's just breaking it down once again, guys. When we talk about the bronchial tree, it starts with the primary, breaks off to the secondary, further breaks off to the tertiary. At the very ends of the tertiary are the bronchioles, and then the terminal bronchioles. And then what's the microscopic element called again? Alveoli. Alveoli. You want to add that to your list and further breakdown of that. Alveoli at the very end, that's the microscopic elements.
Do you have to know like alveolar duct and then the alveolar sac?
No, that's getting too specific. I wouldn't worry about that. Just know how the order of them, the breakdown of the order, that's the main thing to master on that. If you were to have to list those in order, by the way, good thing to remember.
So it would be terminal bronchus and terminal bronchioles and then
And then the alveoli, which is the microscopic element, yes. That's just another picture for your reference, guys. That's giving you a cross-section of that carina area. By the way, this top right picture that you're seeing right here, Once again, if I took a blade and cut the trachea right here, and we're looking down into it, you'll see it? It's even color coded, left and right. I'll show you inside that carina, which is the same thing we just talked about. By the way, write that down. Carina is approximately at the level of T5. That's good piece of info to make sure you remember. Carina is approximately at the level of T5.
So that's considered an axial cut?
That would be an axial cut, yes. And that's just showing you a little bit more, guys. If we're going to break it down to that microscopic element, there's your alveoli. That'd be coming off this little tertiary branch right here at the very end. That's what we're seeing here, is what helps you breathe. That's showing you how those bronchi all correspond with the numbered lobes as well. 1 and 2 on the right side, 1, 2, and 3 on the, 1 and 2 on the left side, 1, 2, and 3 on the right side. Superior, middle, inferior. Superior and inferior. You want to know the actual names of those lobes. And like I said, don't really worry too much about the things like the fissures and the lobes. Know them by name. Really know the number. That's what I want you to remember. How many are on the left? How many are on the right? They are indeed divided up by what we call fissures, but that's a very specific question you're not likely to see. Just to kind of alleviate some of the information overload there. Focus on the numbers, the lobes, corresponding to which side. All right, let's go back to the neck, because this one tends to get a lot of us guys. Once again, anterior portion of the neck, we're just talking about those glands, that thyroid, followed by parathyroid glands. Those are found approximately where again? In front of or anterior to the laryngeal prominence. And that's going to be approximately at what?
C6.
Spinal level, C5, C6. Yeah. C5 most commonly used, but there is a range of C5 to C6. And there's a great picture to have for reference, guys, that breaks down what a lot of you guys are trying to draw. We're going to start from the top, guys. Remember the pharynx, not pharynx, by the way. Remember we talked about that last year? Not pharynx, but pharynx has 3 sections that we call the nasopharynx, the oropharynx, and the laryngopharynx. How do we tell the difference? Well, look at the words. Naso refers to what? Nose. So, of course, that's the most superior portion that is still in the nasal cavity, which we see right here. Now, as we go back towards the back of the throat, there's your uvula, by the way. Back of the throat, oro means mouth or throat. Oropharynx, that's where those 2 arrows there are pointing. We seeing that so far? So from nose to back to the throat. And as we go down, that's when we get close to the larynx area, which is where your vocal cords are. And that's going to be the laryngopharynx. So laryngopharynx is right below the uvula and right before the epiglottis. It's in between those 2 landmarks. So naso, oro, laryngo. These are all part of the pharynx as a whole. So pharynx starts in the nasal cavity and terminates right before the epiglottis. Y'all see that? So what would be after the pharynx? That'd be the larynx, this whole area. Even though you see it labeled down here, that's including the whole area from the epiglottis down to about right here. That's the blue area you're seeing here. It's your larynx. Now, what do we have in the larynx area? Of course, we have the hyoid bone that's the most anterior. That bone, by the way, is one of the only bones that is just free floating in the body. That would be followed by things like the sesamoid bones. They float as well. The hyoid bone is not connected to any other bone. It's just floating there in the front. Then we have the epiglottis, which serves what purpose?
Cover the
That's the flap that covers the what? The trachea, so we don't do what? Aspirate is what I was looking for. Aspirate. Make sure you use that word aspirate. If we aspirate, we are breathing in liquid or solid matter, and it's going to cause us to choke and can actually kill us. So that flap will close off to allow the food or liquid to go down the esophagus to be digested properly. By the way, you'll always mention your swallow function studies. That's what they're usually checking. They want to make sure that epiglottis is working properly, because people that are choking, sometimes that epiglottis might not be shutting perfectly. It might not be completely closing. There's a little hole that food and matter is still getting down, causing the patient to choke a lot. That's the main purpose of the swallow function study, to check the integrity of the swallowing, which involves, of course, the epiglottis closing out the trachea to allow us to digest food properly.
I have a question.
Yeah.
How would they fix that if it's not working properly?
How would they fix that? That's actually a good question.
Steroid injections, I think.
There's some kind of something they can do to stimulate the nerves to make that work properly. It might be steroid injection. I can't recall at the moment off the top of my head. There's things they can do. Very common problem, by the way. If you know people that choke a lot, if you have any failures that choke a lot, it's usually due to that epiglottis, the nerves not activating it properly. Okay. Thyroid cartilage, once again, guys, that's where the thyroid gland is located, right in front of that laryngeal prominence or the Adam's apple. I'm sorry, thyroid cartilage or thyroid gland down here in front of the Adam's apple, and then the trachea is where the larynx ends and the trachea begins. So that would be about at the level of the inferior portion of the thyroid gland. If you want to write in your notes, the larynx terminates at the inferior portion of the thyroid gland, and that's where the trachea begins. So pharynx, larynx, trachea, three main sections of that canal before we get to the actual lungs and the bronchi. Of course, one big thing to remember as well, people always forget, make sure you know the placement of these organs right here. The trachea is what to the esophagus? Anterior, and the esophagus is what to the trachea? Posterior. That's a very common question I've seen come up on the registry and the practice exams, how these two tubes relate to each other with positional terms. Then they might randomly throw thyroid. Thyroid's what to the trachea? It's also interior to the trachea. Trachea is interior to the esophagus, thyroid's interior to the trachea. And then backwards, trachea is posterior to the thyroid, esophagus is posterior to the trachea. Think forwards and backwards on those positional terms. They can be asked any number of ways there. There's about 6 questions right there. Just throwing off the top of my head, they can ask you.
Would they ask in relation to the spinal cord?
They could, I don't foresee that, but that would be the most posterior, obviously. Everything else would be interior to it, possibly. What else? Uvula, we already talked about. Soft palate. Soft palate is the area right behind the hard palate. So, like if you take your tongue, poke the back of your, like the roof of your mouth, like if you're poking your tongue on the top of your mouth, that's hard palate. It feels actually hard, there's bone there. But if your tongue was long enough to go further back, which I don't think most of us have a tongue that long, you'd feel a soft area, and that's the actual soft palate. You can actually palpate with your fingers. You have a soft area on the roof of your mouth, you have a hard area. Hard area is the front, soft is in the back, closer to your uvula. Don't stick your fingers down your throat. I don't need anyone puking in class. But we do have a hard and a soft palate. That usually activates the gag reflex if you palpate the soft palate, by the way. That's what people do when they stick their fingers in their throat to stimulate vomiting. They're palpating that soft palate to cause the gag reflex. Yeah.
What reflex you call it, sir?
What's that?
What reflex is it called? To vomit?
The vomit reflex,
What-
yeah.
what is
People
it?
will palpate the soft palate
Yeah,
to
but-
stimulate the vomiting response.
The term you use, sir, right?
The Greg
Gag.
reflex.
Gag.
Gag.
Oh, gag reflex, G-A-G.
Gag.
Gag
Gag is
reflex.
vomiting.
Well, no, gag isn't vomiting. Gag is just it's like an automated response that can cause vomiting. Like when you go, that's gagging. But then the vomit is the actual,
Good.
comes out.
Right, sir.
Two different things.
Gag is.
Question?
Yeah, so I'm still confused about the thyroid gland and the thyroid cartilage, where they are placed.
Mhm.
Like, so the laryngeal prominence, that's at C5, C6. So the thyroid gland is also C5,
So-
C6.
Yeah, so look, we have 1, 2, 3, 4, 5.
And then the thyroid
5 and
cartilage.
6, there's the glands. Cartilage is just basically like a covering. Cartilage goes from here and all the way down to here. Like when you're seeing that front view of it, in those other pictures, you're seeing that mass of cartilage kind of going all the way down. The gland sits right on top of that cartilage, but the thyroid cartilage is not the actual glands. They're 2 different things, it's 2 different parts of that area. It's just a covering in front of the trachea. The gland sits on top to the lower portion of it, right here.
And on top of the thyroid gland is the parathyroid.
Yeah, correct. Well, parathyroids are actually
Like
inside the thyroid gland.
Yeah.
There's little circles you don't see label on here.
Yeah.
All right, let's talk about the mediastinum, something we often forget. What's the mediastinum? That's a region of the chest containing certain organs. And these are the ones right here. This would be great to write down. I've seen this asked as a multi-answer question. What structures are found in the mediastinum? Well, here you go, guys. Your heart, your great vessels, your trachea, your esophagus, thymus gland, lymphatics, nerves, fibrous tissue, and fat. Really great thing to write down and put a star by. Basically, it's in the sternal area that your heart's located. That's our mediastinum, encased, of course, by our rib cage and spine, in the middle of both. When we say things like great vessels, we're talking about, of course, things like the aorta and the superior and inferior vena cava. That's the great vessels. That's the largest vessels in the body. Aorta and the vena cava. That's the great vessels. Now be careful as well, because trachea and esophagus aren't only found in mediastinum, they're also found in what? The neck and oral cavity areas. So there's a little overlap there. Excuse me, because of how long they are. You will see not included in there is the, what was the other gland we talked about?
Parathyroid?
The thyroid glands and parathyroids. I'm saying that because easy to mix up. They're very similar words. It's just a thymus gland located here. Thymus is specifically in the mediastinum, not the thyroid gland. The thyroid gland is not the mediastinum. But it's just right above it.
I have a question.
Yeah.
You know how, can you go back over?
Mhm.
You know, in the definition it says biosternum anterior, spine posterior, and lung lateral. So would the T-spine be associated with the mediastinum?
It would not, because that's what's saying with the spine posteriorly. It's like the cage around it. So the mediastinum is all the organs and tissue found within that cage. Like if you're looking at that skeleton right there, you look at the rib cage with the spine. Mediastinum's in between all that. So I'd say it's bound. Otherwise, in other words, it's enclosing all those very precious tissues and organs inside that cage.
Oh, so only
So we have the sternum in front, spine back, lungs on the sides.
Oh.
It's all in between that.
only organs and tissue, no bones.
Correct.
But I thought the thymus was on top of the sternum, so then if the sternum
So
is not.
that's the
part of
only
it-
one that gets a little overlap there, is on top. That's the only one though that's gonna be outside that cage. Good thing to bring up, I'm glad you brought that up. Thymus is unique, it sits on top. It's the only thing that's actually, it's actually very easy to damage the thymus with radiation. A lot of people that have a lot of nuclear medicine studies, their thymus gland will completely evaporate away. Because there's nothing protecting it. Kind of like with the thyroid as well, very easy to damage because it's not encased in anything and radiation's going to directly hit it. But you'll find a lot of people that have a lot of radiation treatments, things like a lot of CT exams, radiation therapy, and nuclear medicine studies, they don't even have a thymus left. The thymus gland completely erodes away, which can cause some immunity issues in the future for them.
So it's located behind the nipple.
What?
The thymus gland is located behind.
Right on top.
So it's on
Right on
top.
top. Yes.
Is the aorta also called the great vessel?
Yes.
That's it.
That's what I was saying. So the greater vessels are your aorta and your vena cava.
Oh,
It's the two largest vessel systems in the body. Okay. And of course, x-rays, guys, don't forget your hot spots. Just a few things to review. Remember, we can't really see the bronchi too well on an x-ray. We basically just see the little branches that we call what? Hilar region. You remember that? Hilar region. But sometimes, depending on how much air the patient has breathed in during the x-ray, we can make out the bifurcation area of the carina, which is always in that exact spot you see labeled there. Of course, if we see air in the trachea, we're going to label that as the air-filled trachea. We can see that as well. And of course, everything in between that we can label, which moving forward, we'll take a look at some of that. Y'all remember these little drawings, these little things to reference. Remember when we're labeling a heart on an x-ray, we don't actually call it the heart, we call it the heart shadow. Once again, we also don't call it just the trachea, it's the air-filled trachea. We do call the carina the carina. Of course, right and left lungs. And what else is the important anatomy, guys? You should know it like the back of your hand by now. What's the important anatomy of those lungs? What else we got?
Costophrenic angles.
Costophrenic angles, left and right. What else?
Base.
Base. What else?
apices.
Apices, correct.
And ribs.
Ribs, of course, we're gonna come back to ribs later on the review, but yes.
Diaphragm.
Diaphragm, correct. So remember, I want y'all to be careful on that, by the way, because there's a lot of overlap there, because diaphragm and base are in the same general area. Be careful, and they'll usually specify if they're looking for the landmark on the organ versus a muscular structure. If I say muscular structure, what is it? What would this be if it's a muscular structure?
Diaphragm.
Diaphragm's a muscle that helps us breathe, correct? Now, if it's a landmark on the organ, it's going to be base, because it's base of the lung. Does that make sense? Just want you to be careful, because those two pieces of anatomy are basically in the exact same spot, but they will specify if they're looking for a muscle or a landmark on an organ. Very important to differentiate and make sure you're reading that very closely. Now guys, please, if I can guarantee something will be on your registry, you're going to label a concentric angle. If you miss that question, I won't come after you. Do not miss a concentric angle. And where do I see people make the mistake the most? Where do you think people make the biggest mistake on that? The right versus left. Guys, please. This side is what?
Left.
This side is?
Right.
This side's what?
Left.
This side's what?
Left.
I was trying to get you there. But yeah, left and right, guys. Please don't miss that. That's a throwaway point. And I would be so depressed if I failed my registry because I did not label a concentric angle right on my test. I got 74.
Like, what did I
Don't be that person. Don't be that person. I'm telling you that will be on your test. You will label a concentric angle and or an apex very likely. Very likely. Pretty much saying, yeah, this person can't get this right, and you go back to X-ray school. So, just what I'm saying, I'm not trying to be rude, but just pay attention to details, guys. Don't rush. Read very carefully and make sure you're doing the rights and lefts correctly. So we call it careless error. We're going fast, and you know, just a natural inclination is that's right, that's left. But remember, with X-rays, we look at it in reverse. That's the patient's left. That's the patient's right, like they're looking at you.
And then you said always, if it doesn't have a hard grading, you said always assume.
Always assume you're looking at a PA chest. Yes.
So the apex is just anywhere on the top, right?
Right. So apex is going to be where it's curving. Anywhere where it's curving. Here and here. It wouldn't be like down here or anything. By the way, the outside layer of the lungs, in case they ask, is called what?
Pleura.
Pleura, which is it's right there for you guys. Pleura. Pleura is the outside layer. They're not going to ask you that, but just in case you want to know. Of course, how do we know it's an ideal X-ray when it comes to breathing technique, guys?
10
10 ribs. 10 ribs. 10 ribs. Guaranteed registry question, guys. Guaranteed question for me. Don't miss that. If you miss that one too, I'm still going to come after you. You should know about those 10 ribs by now. 10 ribs for an ideal breath on a chest X-ray. And how do we acquire the 10 ribs? What's the breathing technique?
Second time.
I want y'all to see the whole process though, guys, just to solidify. Take a big deep breath in, blow it all the way out. Another big deep breath in and hold it. And that will fully inflate the lungs with the hopes of getting those 10 ribs shown in the lungs.
You can breathe.
And what they might do is they might show you a chest that is not fully inflated and say, how would you fix the X-ray? And it might look perfect, but if you're not seeing 10 ribs, the answer would be retake with better inspiration. Now, you might not see it at the hospital. Once again, they probably send them through all the time, but I don't want y'all to think like clinic. I want y'all to think like the curriculum. And for the curriculum, if we don't have 10 ribs, we should repeat the X-ray. Are we clear on that? So a lot of people are like, oh, well, we don't repeat it in clinic. The registry does not care about clinic. They care about what you learn in the curriculum. It's 10 ribs or bust, 10 ribs or nut. You have to have 10 ribs or repeats. That's just another picture if you want it, guys. It's super detailed. A lot of stuff on there you don't need to know. I'm thinking I'm just going to go past that. All right, so that's just showing you a pediatric chest. Just for review, guys. If I point up here, what is this specifically? Left apex. Down here would be the right concentric angle. If I'm talking about landmark on the lung, this is the right base. I'm talking about lungs right now, not ribs. If I'm pointing to this area and saying, what's the muscle? You would tell me this area the arrows are referring to as the what? Very good. Lateral view, guys. If I am pointing down here, of course, it's the concentric angle. Once again, they'll specify if they're looking at the muscle or the landmark on the organ. This is referred to the muscle, therefore it's the diaphragm. If they say landmark on the organ, you would say base. Of course, we have the heart shadow, hilar region. You do remember your thoracic vertebrae, yes? We'll review that, don't worry. Of course, sternum's in the front. What's the three portions of the sternum? Manubrium, body, xiphoid process. Top of the lungs being the lung apices, air-filled trachea. What about if we looked at a good old soft tissue neck like this? This is the one that you guys asked a lot to review on, and we're gonna go over the positioning here in a little bit too. So first of all, on the left, we have a lateral soft tissue neck. Is that a optimal radiograph? Yes or no?
No,
Why not?
they're flexing their neck.
First off, the neck is flexed, which we don't need to have on that. But what else?
Yeah, they got the whole shoulder.
Well, we're not really worried about the shoulder. We're not looking at the spine. What's our star of our show?
Exactly.
Soft tissue.
What are we looking at for soft tissue neck?
The soft tissue.
The soft tissue and the what specifically?
Trach-
Right, the air-filled trachea. So from that aspect, would you say it's pretty decent? I would say yes. But you mentioned that the neck is flexed, which we don't want. But what else? What else is wrong with that radiograph? It's practice for y'all's
Collimation.
evaluation class.
And they don't have an anatomical marker.
Thank you. Thank you. We do have an artifact on the neck. Not a C collar, it just looks like a collar from a shirt.
Oh.
Now, why is that a bad thing? Because depending on the thickness of that artifact, that might be obscuring something that the radiologist needs to see in the actual trachea right there. By the way, once again, this is the air-filled trachea, not the esophagus. Please do not label that as an esophagus. What else do we have to comment on? If I was going to break down the areas of the actual airway and say specifically, what is this area up here called?
Nasopharynx.
Nasopharynx. This area would be oropharynx. What about down here?
Laryngeal.
Laryngopharynx. So nasopharynx, oro, back of the throat. Right before the epiglottis is the laryngopharynx. And speaking of that, what's that little spike there called? That's your epiglottis. We all see that?
Mm-hmm.
Easy to miss, but important landmark to be able to label right there. Bone that's in the front here would be the what?
Thyroid bone.
And of course, this whole structure would be
Trachea.
air-filled trachea. But don't forget, we do have the larynx and the trachea if it's on a model. But on an X-ray, this whole structure is just air-filled trachea. Does that make sense? Y'all understand the difference between X-ray and model? Just making sure.
Can you see the esophagus on this?
You cannot. But it would be where? Would it be in front of or in back? Or
Posterior.
it would be behind, right back here, correct?
It's Donahue.
So the breathing
It's solid
instruction
and
is-
ideal, so it's not
is it
aligned
while
to the
breathing?
section CRs.
Well, it's hard to
This is
tell.
like
'Cause it
a
looks like they turn their tube.
It's like an
I don't think it's an issue with the
Level
IR. I
six
think it's
one.
they turn their tube. If I was to guess. Which, why you would do that on a soft tissue neck, I don't know. I guess they're just trying to be creative or something. Yeah.
I remember about the air-filled trachea. You said the top part is the larynx.
So if we're looking at a model,
Uh-huh.
the larynx is going to be the area that's from the epiglottis down to about the thyroid gland or the laryngeal prominence right here. That's going to be your laryngeal area, and then below that's all going to be considered tracheal area. But on a radiograph, we're simply going to refer to this whole area from the epiglottis down as the air-filled trachea.
Okay.
We don't differentiate between the two on an X-ray.
Okay.
All right, on the right side, what is that, guys?
APC spine.
No, it's not apiaxial C-spine.
It does
Oh, trachea. I mean,
That's an AP,
yeah, AP soft neck.
soft tissue neck.
Soft tissue neck.
How do I know that? Because of how clear the trachea
air.
is demonstrated in front of the spine there. Now, they're not going to be so cruel as to give you a side-by-side, like which one's the apiaxial C-spine, which one's the air-filled soft tissue neck. That'd be kind of a sick joke. They would actually specify what you're looking at there. But, question?
Yeah, about that. But you can finish.
But,
Sure.
star of our show, of course, is that air-filled trachea. The main thing I want you to look at here is not only air-filled trachea, but there is a pathology present on that X-ray. Does anybody see the pathology?
Can you turn on the TV, please?
Oh,
Thank you.
What?
now that one's gonna go
It's
off.
just skinny right here.
It is skinny there, you're correct, but what's that called? That's got a certain name.
Oh,
Not obstruction.
Slip, slip.
There we go.
thank you.
A foreign object. Mm-mm.
Well, not for an object. That's got a certain name to it. It's a good thing to write down and remember. It's a pathologic we see specifically on the airway. This is one of the things we mostly look for on these exams.
Is it twisting upon?
You're kind of thinking like
Blocked
the,
airway?
you're kind of thinking like the intestines there.
Blocked airway.
Well, those can cause blocked airways. This specifically is nothing to do
So that's
with the foreign
It's
body.
the tissue that's,
Lymphoids. I don't know.
Starts with an S. Don't remember? We talked about before.
Starts with the S. So,
Exactly.
so
No.
no.
sync can be
Subluxation?
seizures, I think.
Stricture.
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 We have to
Stricture.
Never heard of
Yeah,
it.
So
we
is
have that, so.
stricture like restriction?
Because this is from the same PowerPoint I gave you guys.
Stricture.
It's called stricture.
Talked about a year ago.
That'd be something good to write down. But the narrowing that we see on a soft tissue neck in the trachea would be something we call stricture. Stricture. S-T-R-I-C-T-U-R-E. Stricture.
Narrowing of the soft tissue neck.
Is it only the narrowing of the trachea, or?
Stricture can be found in other areas of the body, but specifically for the trachea, that's going to be a stricture. All right.
So did you define it as narrowing of the soft tissue neck?
Narrowing of the trachea
Oh, narrowing of the.
or the airway. Now, y'all tell me, this is great practice for your class that you're about to have. Optimal or not for a chest x-ray?
No.
And why is that not optimal?
They don't have a-
Anatomy.
You almost.
They don't have an anatomical marker.
Mm-hmm. They do collimate.
You're saying something
It's
quick?
not standing
The apex a little bit. Apices, I'm sorry.
Or it's definitely not centered correctly. Be more specific. How's it not centered
Oh, it needs
correctly?
to be
Centered.
up somewhere over the shoulders.
It's too low.
Those are in the right spot. We're centered too low. How do we know we're centered too low? What's the main?
Yeah, more in the angle instead of.
We're seeing a lot. We're seeing belly down here.
But you can't see the top.
Look, we're almost clipping the what? Apices. So it tells us that we're not at T7. We're centered too low, as you guys said. So when it comes to that correction, what would be the opposite? Like, how would you correct that? We would center more superior. We would center more superiorly to include all the relevant anatomy. Is there anything else wrong with that radiograph? What's wrong with that marker?
It's digital.
It's a digital marker. The reason I harp on that a lot, it's something they're going to throw at you likely in your test, guys. We don't ever use digital markers unless we're just in a hurry, right?
No, we never use
Do we
it.
ever-
it.
Do we ever use digital
Never
markers?
should.
We do not. It must be a physical marker. But and I want y'all to remember to write this down, guys, because I swear people still forget this because they see it differently in clinic. Per the curriculum, if your physical marker is not on that radiograph, you should repeat the x-ray. As impractical as that sounds, and I myself would not do that either because I'm not going to re-expose my patients. Per the curriculum, though, they expect you to repeat it with an actual physical marker. These digital markers are a legal issue that you should not find yourself in if there's ever a court case involved with that radiograph. I saw some hands go up.
I had a question. So
Yeah.
if it's a pediatric and we accidentally clip the marker, and we repeat that X-ray just to get the marker in there?
In pediatrics, yes, you do have, like, at least when I worked there, we did have to repeat them for that, yes.
But doesn't that break the principle of like alarm?
Get him, Johns.
It does, but they pretty much say that the legal aspects outweigh the safety aspect, at least in a pediatric facility.
They don't care about us.
So for the soft tissue neck, I had a quick question. Where do you collimate again?
Where do you collimate?
Oh.
On the x-axis.
No, I know, but like, where do you?
On top of the line.
Oh, I mean, typically, top of the light just needs to be right under the nose. That'd be the maximum you want me to open. We're gonna go over all the positioning now, that's coming up.
Okay, I'm coming for that.
Yeah, we're just doing anatomy still right now. How about this? Critique that for us.
Or this rotation at the back, so,
They're wearing this artifact,
and,
like a sports bra or something.
I heard someone say rotation. How can you tell there's rotation?
Because it's all bent.
No,
No, it's that the spinal cord is bent, so.
The posterior ribs aren't completely superimposed, so we do have slight rotation, yes. The sternum also is not in a complete lateral. If you look at the sternum's actually overlapping slightly on the lungs here. So it does tell us there is rotation present. What else? Someone said artifacts. Where's the artifacts at?
it's kind of like a sports bra, like a band.
Correct. Sports bra, elastic bands, right there. Big no-no. Anything else?
And the marker is right
Is there
almost
tilt?
out of the
The
thing.
marker's on there technically.
Is
Not in the
there?
best spot, but it's technically on there.
Is there tilt?
Tilt.
Like they're leaning down into the.
Probably hard to tell.
That's possible.
Yeah.
The chin is in the picture. The chin
The
is-
main two, of course, is going to be the rotation and the artifact. So would that need to be repeated?
Yes.
Yes. Now, in a practical sense, in a real world scenario, you probably would not repeat that. Let's be honest. Most texts are not going to, but what are we basing it on? The curriculum. Curriculum would say, yes, you should repeat that to optimize that radiograph. Why? Why would I repeat that? Like, what would be my reasoning?
Rotation.
Rotation or?
Artifact.
Why is an artifact undesirable?
Might hide that.
It might cover up a pathology. Good. I just want y'all to make sure y'all remember that, guys. It might be covering up something important pathology-wise.
So if there's rotation, so you have to repeat it.
Per the curriculum, you should, yes.
But in the real world, you know you ain't gonna do it. Next.
We teach this evaluation criteria
They do it
because
all the time.
technically, with evaluation criteria, if your image is not meeting the criteria, you technically should repeat it to optimize that, give the doctor the best possible image. That's how they
That's your
justify
friend.
it. Now, pathology, the part we just seem to be really hung up on is pathology. I've got a lot, there are gonna be ones we already talked about, but I've also added some new ones when I was reviewing Merrill's to make sure that you keep them in your knowledge bank that I know have been coming up on the tests. So some old and new mixed in here. Here's some new here, of course, aspiration. We talked a little bit about that, guys. Aspiration is what specifically again? What is aspiration?
When something goes into the trachea, so.
When a solid or liquid is breathed into the trachea and not properly swallowed. And once again, what do you think of? You think of your swallow function studies, or checking that epiglottis, make sure it's shutting that trachea off properly. That can be any type of matter, of course, guys. That can be, well, everything except air, because air is supposed to go in there. It can be liquid or solid that you aspirate. What's the most common type of aspiration we see in a hospital setting?
Water.
Vomit, vomitus. Which is why, once again, we talked about patient care. If a patient is seizing, what do we do with their head?
Turn their head.
Turn to the side so the vomit will go to the side and they won't breathe it back down. Very important aspect. Now, of course, aspiration is dangerous because it can lead to aspiration pneumonia. And that basically is whenever that object or that liquid's in the airway, it causes an infection and causes mucus to build up in the alveoli and gives that patient pneumonia. Infection sets in. So aspiration can lead to aspiration pneumonia. That'd be something really good to write down and remember. Aspiration can lead to aspiration pneumonia. That's kind of what it looks like on an x-ray there. Just looks really cloudy and ugly like you see right there. That's a CT on the right side.
You said that aspiration pneumonia, it causes an infection, it turns into an infection.
It can turn into an infection, yeah. If it's not removed.
That's when they use a chest tube to remove it.
Huh?
They use a chest tube to remove.
The drain out if it becomes too thick, yeah. The chest tubes are mostly for like if you have like a pleural effusion, something like that going on, like actual fluid.
Yeah, those pumps and how to pull it out, because that.
Usually when it comes to pneumonia, they're gonna break that apart with like antibiotics. I had pneumonia twice, so when I was a little kid. They had me, I don't know if they still do this, but in the 80s they used those big air tents. I just looked like this big giant air tent, it had like a medicated air in it, and I breathed it in and it broke apart all the mucus. That's my earliest memory as a kid, by the way. My earliest memory as a kid was when I was 2 years old with pneumonia, and I was sleeping in that tent. It's like it's one of those images that's always been in my mind, I always remember. I was sleeping with my teddy bear, that's what I remember. I still have that teddy bear, by the way. All right, so I mentioned this already, pleural effusion. What is that, guys? In simple terms, water on the lungs. So that is a buildup of fluid between the layers of pleura. It's not actually in the lungs, guys. I want you all to remember that. It's not actually in the lungs, it's between the layers of pleura. So you see the actual interior lung here. There's that pleural outer layer. The fluid builds up in that area between the pleura and the lung itself, right here. So it kind of compresses up against the lungs, causes a lot of pain, difficulty breathing. But I think that's the main thing I see people mess up is they think that's actual fluid in the lungs. And people even say it, claim, oh, they got fluid in their lungs. Well, no, it's actually in the pleura, pleural space between the pleura and the lung itself. Thus the name pleural effusion. Does it say lung effusion? No, it says pleural effusion, which is an actual separate layer on the outside of the lung. So keep that in
In
mind.
the pleural cavity.
Pleural cavity. So that's where you most commonly see your chest tubes, guys, where they'll put that tube in the chest and drain that into those rectangular apparatus on the floor through the retrograde action. By the way, great patient care question for those chest tube devices. Do we ever move those off the floor? Well, we might have to
We
sometimes, though,
can.
right?
But this has to be below the chest.
So if they're being transported, obviously we can't have it dragging on the floor behind them. So what would we do?
Keep them below the chest.
You hang it on the bed below the chest still. So they usually have a little hook that you hang them on. The main thing is always keep it below the chest so that that retrograde action is still pulling the fluid out. You never put it on level or above. Because what would happen if I took one of those devices and I held it up? What's going to happen?
Probably
It's going to
go
go back in. And of course, we're going to probably be having to look for another job too. Don't be having that fluid go back in the patient's chest.
So what is this machine that you're talking about?
Chest tube machine.
Chest tube machine.
I'm sure you've all seen that by now when you're going to the rooms with portables. They're on the floor. They're like a rectangle, like a box. You see the fluid going in there, tubes. So you want to hit the one with the machine yet? Please don't do that. You might rip the tube out of their chest. That's very painful, as you can imagine. Okay, pneumothorax. So I want you to make sure you know the difference between pneumothorax and pleural effusion. I see people using those interchangeably, but break down the words again. Pleural effusion, once again, is water on the lungs or fluid in the pleural space. Pneumothorax, pneumo refers to what? Air, thorax, chest, air in the chest. Break the words down, guys, it's going to help you. So that's presence of air or gas in the cavity, once again, not in the lungs, because the lungs already hold air. That's the area between the lungs and the chest wall that can cause the lung to actually collapse. So I want y'all to realize this is not an accumulation of air in the lungs. The lungs are supposed to have air in them. It's how we breathe. It's the area between the lung and the chest wall causing pressure. And as you can see, it causes that lung to like shrink down and or collapse, which if it collapses, we can't breathe. By the way, there is an actual word for a collapsed lung.
Atelectasis.
Atelectasis. Remember that one as well. Please know that term, atelectasis. So a little overlap there. Pneumothorax can lead to atelectasis, which refers to a collapsed lung. Okay, tuberculosis. Of course, most of us are familiar with that. It's another infectious bacterial disease. How's it defined? It's the growth of nodules or tubercles in the tissues, especially the lungs. It's just an advanced bacterial infection that creates nodules or tubercles in the tissues in the lungs. Of course, those tissues become infected, causing pain and difficulty in breathing. Highly infectious. We need what kind of mask for the TB patient?
N95.
N95, correct. What kind of precautions do we take these patients? Like
Airborne.
airborne precautions, correct. Very good.
Yesterday, Laura, my first patient was a TB patient, and the doctors were asking like, do we need a gown? I'm like, for airborne? I was like, no, we just need an N95.
It's kind of sad how much they don't know sometimes. Huh?
I was like, for contact, you need a gown.
What did she
But
have?
like you're the
Did they have
physician.
anything else?
So, just one thing to keep in mind, not identify it on an x-ray as well, guys, not only for your test, but for your own safety. You may not know a patient has tuberculosis, but then you take an x-ray, you see something that looks like that, what's gonna be your immediate action if you see a X-ray that looks like this and they didn't tell you the patient had TB?
Yell at the nurse.
Get out.
Start
Get away.
Well, of course, you're gonna
Disinfect.
immediately put a mask on, you're gonna take all the precautions, you're gonna inform somebody, you're gonna wipe that whole room down, you're gonna sterilize it as best you can. Because that does happen sometimes. A lot of us get exposed and don't know it. That's why we get TB tests so often. Hands who was first.
You can go, you can go. No, just go.
What is the, when a patient, I don't know what disease or whatever they have, where you have to clean the room with bleach and water?
Right, MRSA.
You know, oh, okay.
MRSA?
Is it just
Sepsis.
like bleach and water, or you have special those?
That's minimum
top?
bleach, minimum bleaching water, but usually like cavity wipes are one of the best
Is
things
it the
to
orange
use.
top ones you use?
The
Okay.
strong ones.
Okay.
Yeah, bleach my, bleach my.
No, the purple ones are like the standing. They have
Yeah,
the orange.
they have
They
the
rarely
orange
have
tops.
them.
Yeah, you don't see the orange tops no more.
They have like the ones that say the Clorox.
Yes,
Yeah.
with that Clorox
Clorox
thing.
does wonders, Clorox bleach.
Clorox was really
They
strong.
have the wipes that's Clorox in it.
I hate
I
that
didn't
smell.
realize
I had to
that
be
the
sweet
wipes
smell.
with the plastic thing, it was all that.
Samantha, other questions?
No, just to kind of add on to what you were saying. Anytime I'm in the hospital, I will still wear the N95. I know a lot of us are like done with it, but it happened at least 4 times on my Bentab rotation. We found out after the fact that they had TB.
And that's your choice to do that. And you always have the right to do that as well, to wear that mask as much as you want to. N95, whatever you want to wear. Because it does happen more often than you realize. And you get exposed to, well, especially, good Lord, pediatrics. I got exposed to stuff every day. Because my immune system was a beast after I worked there for 10 years.
Well, our tech was put on the N95 every time we would go do a portable. She's like just for.
The other thing I caught the most when I worked at TCH is I always had a stomach bug. Like every other week I was throwing up from a stomach bug. Because if you know anything about kids, they get stomach bugs and pass them around like crazy. And those viruses just mutate and come back.
The bugs on the kids are equally strong to get adults as well.
Oh yeah. Oh yes. The stuff kids carry, whew, man, nobody's safe.
Is your name come to, compete at an airfield trip at Fort Thomas?
In a what? Repeat an airfield trach, like in a soft tissue bag. Why'd you only get it 4 times? I didn't say name names, but okay. Enough said, okay.
They were trying to be precise. That's the way it's gonna
Hey,
say.
you know, as
Like
a
Mr.
tech, that's your
Funk said.
choice. As a tech, that is your choice. Some people are very thorough.
Mr. Funk said, try to say it nicely instead of badly.
Feels like Fort Thomas.
That's why I asked you where he's.
Where do you call it?
No, you don't need to be that far up. Okay, pneumonia, guys. Another viral infection. Make note, pneumonia is virus-based. It's an actual virus. It causes lung inflammation, and the air sacs will fill with pus, not liquid. A lot of people think pneumonia is liquid. It's actually pus that builds up in the air sacs, and it can solidify. And of course, if it solidifies, you can't breathe. Which is why I was saying when I was a kid, they put me in that tent because that stuff I was breathing in was supposed to break down the pus so I could breathe better. It worked. I don't think they use those anymore, but it worked. Now these give you antibiotics, different breathing apparatuses to break that apart, depending on how advanced the pneumonia is. Pneumonia can be very serious, or it can be minor. You have what's called walking pneumonia. You ever heard of walking pneumonia? Very minor case of it. Very contagious as well. Usually looks like a cloud on the lung in one spot right here.
So it can be both bacterial and virus.
Mostly viral, but it's an overlap of both, yes. It's mainly viral based.
So this person just had number one, but you can get it in both.
You get in both. I think most commonly what I always saw was in either one or the other lung, typically, at least on kids. That seemed to be the most cases I saw. All right, of course, we already talked a little bit about that one, guys. Aspiration pneumonia. First, if you aspirate, it becomes infected. It can manifest and become aspiration pneumonia. Nothing too complicated there. It can be food, saliva, liquid, vomit, be one of those common ones, and even contrast, like you see on the picture on the right there. Obviously very painful. If it can solidify, it gets that far in the bronchi, it can cause severe pain and infection because that's not supposed to have any kind of solids or liquids in there. It's supposed to be air only.
Is that really contrast?
That's contrast. So that's when it choked on contrast and
Oh.
aspirated it.
Oh,
They gotta go into surgery, don't they?
That would be yeah, that would need to go to surgery. That's very dangerous. 'Cause you see how much is in there? A person probably can't hardly breathe at all.
How do they get it out?
They can suction it out. That wonderful noise, the suction noise.
I don't think.
So will it look white? Like once they go in, it will
Depends
look.
on the type of contrast. That might be gastrographin, which is clear. Or all the contrasts come up as white on an X-ray, so not necessarily just barium. Now, hopefully, that is something like gastrographin, because barium would be more dangerous to aspirate versus the water soluble, like we've talked about.
So if it was a water soluble gel still.
Oh, you'd still try to get it out, but it would be less of a danger. You would have like more time to.
Yeah, iron is more dangerous than barium.
Yes.
It's contradicting.
Seems that way, but atelectasis again, guys. Atelectasis is a fancy way of saying collapsed lung. That comes up a lot on questions in regards to technique. So, great situational question to think about, guys. Patient presents with atelectasis of the right lung. You see the X-ray there. What would you do with your radiographic technique? Would you increase the mass or decrease the mass? And why?
Increase.
Decrease.
I'm hearing both. So I heard increase first. Why would you increase the mass?
I just guessed.
Just guessed. All right, so whoever said decrease, why would you decrease it?
There's a
There's-
lot of air in the lungs, so it's easy to penetrate.
Basically correct. It's easier to penetrate. So the lung's collapsed. The tissue's not there. So if there's less tissue, we're going to decrease the mass because there's less to actually penetrate. Versus if there's more tissue there, we're going to increase it.
Oh, yeah.
So you're gonna see a lot of situational questions like that. Because another one we talk about in a minute, I'm gonna quiz you the same way. And I want you to think about it. Think about how much tissue is there, how healthy a tissue is, and that's how you're gonna determine if I raise my mass or decrease it. They actually give you a lot of questions like that. You're gonna have some of those on your test, your next test as well.
So how come the right side doesn't show black?
Because it's completely collapsed. There's no air in there. It's like shriveled up. Even smaller than you see right here. Like it's just like a deflated balloon, essentially. That's a severe collapse you see right there. Sometimes you'll see a little bit of lung, like you'll see like a little tiny lung right here, or like right here. This is a complete collapse of the lung right here. There's zero air. So that would technically cause you to lower that mass because you have less to penetrate overall. That'd be the action you take as a radiographer. Right, we can see, you can kind of see where the bifurcation is taking place as well. There's the trachea, there's the carina. As you can see, there's nothing there. You can barely make out a little bit of air there, but it's just a deflated balloon essentially that you're seeing.
Like in pneumothorax, you can see a lot of black.
Yeah, because there's more air causing the collapse. So as a pneumothorax, you would see a layer on the outside here, pressing up against that, what's left of the lung.
So this is probably a collapse or something else.
Yeah, it doesn't have to be pneumothorax that causes collapse. That can be another issue. It can be a punctured lung, whatever. Someone gets stabbed with a knife, that can cause a collapsed lung. A shot, yes.
So you decrease the mass because you want to increase the
You're
contrast.
decreasing the mass because what's mass do? Mass is going to help penetrate, give you a better image. So if I have less tissue there, I want to bring the mass down to get a better picture. A few other ones, guys. I think I brought this up to Melanie. She was talking about bronchitis. What is bronchitis, guys, in simplest terms? It's inflamed bronchi, which is what you see right there. The opening closes off because it becomes swollen. It's a swollen and or inflamed bronchi. That's bronchitis. Now, COPD, we've all heard of that. Very common pathology, chronic obstructive pulmonary disease. Basically, that's an advanced case of bronchitis. So on the left, you see a normal bronchial tube. On the right, you see an inflamed bronchial tube. So COPD and bronchitis overlap a lot, but COPD is a more advanced case of bronchitis, which can be more life-threatening. Does that make sense? Why? Because it's in the word, chronic obstructive pulmonary disease. Bronchitis on its own, a lot of people get that in their daily lives. you can recover quite easy from that. But if that becomes more infected and advanced, then it becomes chronic and causes more severe obstructions of the pulmonary system. That's why it's chronic obstructive pulmonary disease. So, as I said, it's a more advanced case of bronchitis. Great to write down because people often mix those two up. And then what's cystic fibrosis? Well, based on the picture, can you figure out what that is? Kind of similar, but different. So I put these three together. Cystic fibrosis is specifically a
Bacterial
infection, but
that leads
what
to
is it,
this.
guys?
Cyst, it makes a cyst.
It's a narrowing again, but it's caused by mucus. So these two are caused by inflammation. Cystic fibrosis is caused by mucus buildup. Really great to write down those three, guys. People always get those three mixed up because they're very similar but different. Bronchitis is simply inflammation of the bronchi. COPD is an advanced bronchitis that becomes life-threatening. So basically multiple bronchi become inflamed and closed off. And then finally, cystic fibrosis is a bit of a mucus that's going to block those bronchi. All causing issues breathing, all causing infections, and of course could be life-threatening. A lot of people, for some reason, always think COPD has to do with the heart. And I guess in comparison, it could eventually cause heart issues, but it's mainly to do with the breathing, and the bronchi specifically. Because if you're not getting enough air, of course your heart's not going to function right either. It's more directly related to the bronchi becoming inflamed. All right, there's a big one too, guys, emphysema. Now, based on that picture, there's a reason I'm not putting text on here because I want you to figure it out for yourself. What do you think emphysema is? Just look at the picture and you can kind of describe, you can figure out what it is. What is that?
It's the infection of the alveoli.
Well, not necessarily infection.
Perforations? Like burnt out.
So we see the word damaged alveoli. Basically, it's just a degradation. It's the alveoli dying in the lung. It's basically the lungs are kind of rotting away. And in retrospect, it's what a lot of smokers develop is emphysema. Just basically the alveoli become damaged and start to decay. And then, of course, the actual tissue of the lungs begin to break down. They become porous, like you see right here. Now, a little hard to see on an x-ray. If you look closely, you can kind of see the pores developing. But the main aspect of emphysema is the lungs become very porous. And porous means holes, because bone can become porous. Yes, like osteoporosis, same concept. So let me ask you all a situational question again, because this is directly from the registry, this question right here. If a patient presents with emphysema, what do you do with your mass to compensate?
Decrease.
I heard two people say decrease. Why?
Because there's less tissue.
Because the tissue is decaying away. Therefore, there's less lung tissue. To get a better image, I'm going to bring the mass down because there's less to penetrate overall as the lung becomes more porous. That is directly from the registry, guys. Since I already said osteoporosis, if a patient has osteoporosis, the bones become what?
Brittle.
Brittle.
More fragile and porous. Therefore, if a patient presents with osteoporosis in their femur, what would you do with your technique? Decrease mass. Why? There's less bone tissue. It's becoming more porous, more holy. More holy. Oh, yeah, more holy.
So the other thing that we were discussing, the bronchitis, the COPD, and the cystic fibrosis, would you go up?
Well, it depends. Those first two, that's not really going to affect your image that much. But the last one, if there's mucus present, we increase because there's more tissue. Mucus becomes thick, like pus. So that's part of that critical thinking. Think about the pathology. Think about what's doing to the tissue around it, and that's how you would adjust your techniques. Is that making sense? So what would be the opposite of osteoporosis? Since we're already talking about all this.
Petrosis, yeah.
Osteopetrosis. So what's that referred to?
Hardening of the
Hardening.
bone.
Bones getting thicker and harder. Therefore, what we do with the technique there? Increase it, it's a thicker area to penetrate. It's starting to click. You get that, guys, if you master that concept right there, you're going to answer a lot of pathology questions. Most of your pathology questions revolve around how do you adjust your technique in accordance with that pathology. So going back again, atelectasis was what?
Decrease.
So that's
Less
the-
lung, so what do we do with our technique?
Decrease.
Increase it because there's less lung that penetrates. Clicking, good?
Other than the pathology, is there anything else that's wrong with this patient?
Looks like I got some rib fractures. Here, they've had heart surgery.
They probably did CPR.
Not necessarily.
What are those?
You don't need clips like that for CPR.
No, I'm
Oh,
saying
you
they
said
probably
the
did like
broken
CPR.
Oh, they made-
broken
oh, I see
spine.
what you're saying.
What are those like oval things or like on the spine?
These are surgical clips. That means that they cut the chest open at the sternum for heart surgery. And that's how they put it back together.
What about the dark white in right here beside the clips?
Decrease.
That's,
Just calcifications or?
let me see, can't really see that close. That looks like it's just part of the heart shadow and or the, you know what, that might be the aorta being a little calcified. Because if I'm looking at it, aorta's up here. I know it curves down like this. That's my best guess. Or just might be the emphysema built up really bad right there.
Could be the emphysema, it's all fuzzy.
Huh?
It's all fuzzy, so it could be the emphysema.
Okay, 5-minute break because I need to catch my breath. And then we'll wrap this up. We got about 30 minutes left. Take about
Woo!
5 minutes stretch. Let me catch my breath. So I'm about out of juice too. Okay, guys, so soft tissue neck. Biggest thing, of course, we need to know, why are we doing the exam? Main reason for soft tissue necks, not the only reason, but main reason, of course, is going to be the presence of foreign bodies. Things like fish bones or toys or whatever, food, things lodged in the throat, foreign bodies, but also strictures, swelling, especially the epiglottis. And by the way, the swelling can cause a stricture if it overswells, masses, and actual fractures of the larynx and the hyoid bone would be other reasons, but the least likely that we'll see. So number one reason, of course, is foreign bodies. But those other three are other reasons we may need to do a soft tissue neck, as you've probably seen on the orders when they come in at the clinic. Of course, some of the past artifacts, you guys already know that. So AP soft tissue neck, of course, the main cassette. And make sure you know your cassette sizes, guys. Don't forget that small little detail. Sometimes we overlook that. At maximum, you should be using a 10 by 12 cassette. Smaller area, but not so small that we need an 8 by 10. Now, of course, the AP is going to require a 40-inch SID. As you'll see on the lateral, we're going to, increase the SID to 72 to compensate for what? OID. Now, patient position, patient can be laying down, but it's preferred they be standing upright. It's going to give you the better breath. It's going to give you the better image overall. So upright would be preferred for both your AP and your lateral soft tissue neck exams. Put the red once again at cassette size, just because it's a little fact people often overlook. Know your cassette sizes as well, guys. Know what the max is, know what the minimum is. At maximum, 10 by 12. You would never do a soft tissue neck on a 14 by 17 unless it's like a digital cassette and it's all we have. It's just overkill, way too much.
How does using a bigger cassette affect the image again?
So we just bring the overall quality down.
What did you call it?
And really it's because of human error / laziness. Let me put it this way, the bigger your cassette, the more likely you're just to leave it
Open it
open.
up.
Whereas a smaller cassette kind of forces you to do what? Collimate down to that minimum size. So it's a safety thing, and it's really a quality thing as well. All right, what's the part position? Well, MSP, standard perpendicular midline of the grid. We're gonna extend the patient's neck slightly. When we say extend, what are we doing with the neck?
Lift the chin.
Slightly lifting the chin a little bit. Now, not so much that it's way back, just a slight extension of the chin, guys. Very slight. And that reason is for what? Why do we extend the chin? Do you know why?
So they can come in the pictures.
To get the mandible out the way.
To get the mandible out of the way, correct. Get the mandible as much out of the way, the air-filled trachea area as possible. It does obstruct it if we have the patient's head down and relaxed. Central ray, guys, is going to be at the level of that laryngeal prominence, which lines up with what vertebrae again?
C4.
C5, C6. So be careful because C4 is used on what? Apiaxial C-spine. Now, a lot of people assume this is just like an AP axial C-spine, but it's not. We're the two key factors, not only the centering, but you see the word axial in that description at all. It's simply AP soft tissue neck. Therefore, we do not add angles. And if you see it in clinic, once again, we do not add angles to our soft tissue neck x-rays. That's a perpendicular central ray at the level of that laryngeal prominence.
If you angle it, that'll be like a C-spine. If you angle it, it'll be like a C-spine.
It would look just like a C-spine, yes.
The one that we looked at earlier though looked like it was
If it was a mistake, but it should not be angled. Now, exposure, breathing technique, big thing to remember, because you gotta think about what's the star of my show? My air-filled trachea. If I'm not breathing in, am I gonna see air-filled trachea? I am not. But we're in danger because we can still miss it with breathing in. Because if I just take a big deep breath and hold it, am I gonna see air-filled trachea? I am not. When do we take the exposure? During slow inspiration to ensure trachea is filled with air. So we tell the patient to do what?
Take a slow
Breathe in, breathe out slowly, and you catch them as they're breathing in. Key aspect on that exam. So you'll probably see some text where they tell them to hold their breath, and they'll get a really bad picture because they're not getting that fully inflated air-filled trachea. It's got to take place during the actual inspiration. All right, so evaluation criteria, of course, proper collimation along the x-axis. That's going to be that horizontal collimation. And we must have an air-filled upper airway. Otherwise, we need to repeat that x-ray. Now, the only reason we would not repeat it is if there's some kind of major pathology going on, like a major stricture, or a big foreign body that's keeping the patient from being able to breathe in properly. That'd be the only exception there. And of course, no rotation. We want them to be in what we call a true lateral. Red things are the main points on the evaluation criteria for that AP soft tissue neck. And of course, that's the way it should look right there. We see that same pathology as before. That's that same picture, by the way. And I can see what you mean by that looking angled. I don't think that's angled. I think this patient has a long neck. Because I don't see distortion on the other areas of the mandible or the ribs.
Daddy long.
Daddy long neck.
And that's one that's been centered a little bit too low. Let's talk about the lateral. Once again, what's that cassette size? It's going to be the same. It's the same general area, 10 by 12. By the way, lengthwise on both of those. Think about, make sure you know your orientations. Think about the part and the way it sits in the body. The neck is long, not wide, therefore lengthwise, 10 by 12 cassette. And I want you to write both these down because there are variances on this. Per Merrill's 40-inch SID is acceptable, but you are allowed to also do 72 on this exam if you want to write that in your notes. Will they give you both choices? No, they will not. We will go with what Merrill suggests because Merrill's is the more the gold standard. But you can go ahead and write that 72 is also considered acceptable. Why? To mitigate the OID that occurs because of the shoulders. Both are considered okay. Once again, standing would be superior of two. If they have to sit down or lay down, we would do cross table, of course. But standing is going to be the best key for that. And then for the patient's position, of course, we're going to have them semi-puff their chest out, but not too much, not like a sternum. They're going to clasp their hands behind the body to get them out of the way. We want to roll those shoulders backwards because the humerus might obstruct the trachea if we're not careful. And extend the neck slightly as well. The main point that people often forget is that you do need the shoulders to be posterior. We can't have the shoulders anterior or relaxed because it will obstruct that air-filled trachea that goes down quite low, as y'all guys remember with the anatomy. It does go quite low in the chest. So we do that by clasping the hands behind the body and rotating those shoulders posteriorly. That's that weird Photoshop cartoon guy again. Remember that? He doesn't look human.
AI generated.
He looks like a mannequin.
The AI.
Now he's become familiar, so he looks better. So.
What's up?
Now we've become familiar with him, so he looks better.
Oh.
He needs to sue his boss.
She said, now that I know him.
Oh.
And of course, central ray, guys, is still at the level of the laryngeal prominence, but going through that MCP. Don't forget those small details like MCP, SP. MCP stands for
coronal. Oh, MCP, coronal.
And then same as the AP guys, Seems like common sense, but people miss this small little fact. Exposure is made during that slow inspiration to ensure the trachea is filled with air. Not whenever we have a full inspiration and hold it. It's actually during the inspiration. AP, airway, or soft tissue neck is unique in that we're taking the exposure as the patient breathes. Because we want to catch that air in the air-filled trachea, because that is the star of our show. We're not worried about the C-spine, we're worried about the trachea. So I think one thing to really make a big star on, guys, just because I foresee somebody making this mistake, is on that AP, we're not adding an angle, guys. It's a perpendicular central ray on that AP. Even though it looks just like a C-spine, it's not a C-spine. We're looking at the airway. And the mistake I probably see the most is that people will do it like an axial C-spine, or answer it like an axial C-spine. Probably see some texts do it just like an AP axial C-spine. It should not be, it's perpendicular. All right, evaluation criteria. Of course, we want that proper collimation once again along the x-axis. On both those views, we can leave the y-axis open because it's a longer area. And of course, because we are focused on the airway, it must be air-filled, otherwise it must be repeated unless there's some pathology or foreign body in the way. No rotation, that's just telling you, how do you know it's not rotated? Make sure all those structures are superimposed properly. Intervertebral joints are nice and open. Grami are also superimposed. If you see any kind of tilt going on, anything that's rotated, technically, part of the curriculum, we should go ahead and repeat that and get that nice true lateral, represent that airway properly. And remember, when we say something's lateral, we're also saying it is in profile. So the air-filled trachea is in profile on this lateral view. A lot of times when we're referring to the stars of our show, we're saying that particular anatomy is in profile. Depending on the view we're talking about, of course. If you think about a profile, what's another way we use the word profile? Doing it someone from the side, profile view. That's something to help you remember. And that's just showing you what a more optimal soft tissue neck would look like. Oh, that's a little bit posterior for my taste. By the way, if you see in your book a lot of these extra anatomy things labeled, I'll tell you what you don't need to know. You don't need to know laryngeal vestibule. Don't need to know thyroid cartilage, because you actually cannot see that on an x-ray unless it's heavily calcified. You don't need to know infraglottic cavity either. You need to know trachea, epiglottis, and hyoid bone. Those three you definitely need to remember. There's three in the middle, not so much. The person's initials with the L looks like pounds.
Yes.
Just noticed that. It's kind of cool.
Is that Leah? Leah Benavides?
No, this is from the book. All right, that's where I'm stopping today, guys. I'm out of juice. I know y'all are tired too. So we'll pick up with the chest views, the specialized ones, and of course move on to the abdomen on Thursday. Any questions? Thank you, guys. That'll do it. Enjoy your lunch.